Every single year, there's this microscopic parasite that wages a war inside tens of millions of people. And the weapons we use to fight back? Well, let's just say they're not nearly as perfect as you might think.
100,000. That's how many people die every year from amoebiasis. It's a parasitic disease that's incredibly common in low and middle-income countries. And trying to treat it effectively has become one of modern medicine's quiet but really persistent challenges. So to really understand this fight, we first need to meet the enemy.
So the villain of our story is this tiny protozoan called Antiamoeba histolytica. You get it from contaminated food or water, and then it just sets up camp inside you. Now, about 90% of the people who get infected don't show any symptoms at all. But for that other 10%, that's when it becomes an invasive disease. And the people at the highest risk? They're always the most vulnerable: kids, pregnant women, and the malnourished.
To get how we fight this thing, you first have to understand how it attacks. See, the parasite doesn't just hang out in one spot. It actually wages a war on two different fronts inside the body, which means we need a two-front strategy to fight it back.
Think of it like this. The parasite has a base camp right inside your gut. That's what scientists call the lumen. These are the luminal parasites. But then it also sends out these little invaders that burrow into the bowel wall and travel to other places, like your liver. Those are the systemic parasites. So you can see why you'd need different kinds of drugs to go after each of them.
So this all leads us to three main classes of drugs. First up, you've got your luminal amoebicides, something like diloxanide, and their job is basically to clean out the gut. Then you have the systemic ones, like emmetine, which hunt the parasite down in your body's tissues. And finally, you have what are called mixed amoebicides, which, you guessed it, try to do both jobs at once. And the most famous one of those, that would be metronidazole.
For decades, that mixed drug, metronidazole, has been the undisputed champion. It's the go-to treatment for invasive amoebiosis all around the globe. But this is where our story takes a bit of a turn.
And I mean it when I say it's the standard. It's not just a treatment, it's the standard of care. It's even recommended by the World Health Organization. For decades, if a doctor even suspected invasive amoebiasis, this was the very first weapon they'd reach for.
But that brings up a really important question, doesn't it? Is this so-called gold standard actually good enough? Does it really, truly finish the job? Well, the evidence suggests probably not.
Okay, here's the problem in a nutshell. While metronidazole is great at killing the invasive parasites in the body tissues, it often fails to clear the parasite's cysts from the colon. And the result of that is staggering. The parasite sticks around in 40 to 60% of patients. So yeah, they might feel better, but they're still carriers, still able to spread the disease. Now add in the notoriously awful side effects like nausea and this weird metallic taste, and you can start to see why the gold standard is looking a bit tarnished. All these flaws have sent researchers hunting for a better option. So a major Cochrane review, which is one of the highest standards of medical evidence, sifted through all the studies out there to see if we had anything better in our arsenal. And a pretty promising challenger popped up: Tinidazole. It's in the same drug family as metronidazole, but the review found it may be more effective at actually curing the symptoms, and it's probably associated with fewer side effects. Sounds like a clear upgrade, right? Well, here's the catch. The review authors basically stamped their own findings with this phrase, low certainty evidence. What that means is, while there's a hint of a benefit, the studies themselves just weren't strong enough for us to be confident in the results. And for doctors on the front lines, maybe better isn't a very reassuring answer.
So, okay, what about that two-front war? I mean, logically, hitting the parasite with two drugs at once, a systemic one like metronidazole and a luminal one like diloxanide, that should work better, shouldn't it? And while this combination may be more effective at a full clear-out, we're right back to the same old problem. The data is weak, and we're just not certain which specific combination is the best one to use.
And this quote from the review really gets to the heart of the whole problem. We are making treatment decisions for a disease that kills 100,000 people a year, based on evidence from small, often poorly designed trials, most of which are over 2 decades old. Just think about that.
Now, this isn't just some academic debate about the quality of evidence. Choosing the wrong drug or using one without really understanding its risks can have devastating consequences. Let's look at one last example.
This is iodokinol. It's another one of those luminal amoebicides, used to clear cysts from the gut, and for a little while it seemed like a pretty useful tool in the fight against amoebiasis. But it came with a really dark side. It's been linked to some severe and sometimes irreversible side effects. We're talking nerve damage, seizures, and most terrifying of all, optic nerve damage that can lead to blindness, especially in kids. The risk became so clear that the American Academy of Pediatrics issued this incredibly powerful warning, basically saying you should not use this drug in children. It's just a stark reminder of why having high-quality, modern safety data isn't a luxury. It is absolutely essential.
So this brings us right to the central dilemma here. We're facing a major global health threat, but we're fighting it with this arsenal of old tools, guided by old, uncertain evidence.
Okay, so let's bring it all together. What have we learned? We've got a deadly, widespread disease where our gold standard drug fails to cure up to 60% of patients. Our most promising alternatives are backed by flimsy evidence from a generation ago, and some of the other drugs in our arsenal carry these truly unacceptable risks.
Which leaves us with one final, unavoidable question. For the 50 million people who get infected every single year, and for the 100,000 who die from it, is maybe better really good enough?